COPD Gold Guidelines 2026 Part 2. In this video, we will be focusing on management of stable COPD. In this video, we will be focusing on management of stable COPD, pharmacological treatment, non-pharmacological measures, and palliative and end-of-life care in advanced COPD. Goals of COPD treatment. Goals of COPD treatment are both symptomatic and prognostic. First, we aim to relieve symptoms such as dyspnea, cough, and exercise limitation. Second, we want to improve functional capacity and quality of life. Third, we try to prevent the disease progression and reduce frequency and severity of exacerbation. And finally, some interventions are known to reduce mortality. Effective COPD management must address all these goals simultaneously. Management framework of COPD. COPD management is individualized. Treatment decisions are primarily based on symptom burden and exacerbation history. In addition, blood eosinophil count help guide decisions regarding inhaled corticosteroid use. The overall management plan includes four key components: reducing risk factors, initiating pharmacotherapy, implementing non-pharmacological strategies, and ensuring regular follow-up and reassessment. Continuous management cycle in COPD. COPD management is not a one-time decision. It is a continuous cycle of assessment, adjustment, and follow-up. At every visit, symptoms and exacerbation history should be reviewed. Inhaler technique must be checked because incorrect inhaler technique is a common cause of treatment failure. Adherence should also be assessed. Based on this information, treatment may be escalated, switched, or de-escalated. Pharmacological treatment in COPD. Initial pharmacological treatment. Initial pharmacological treatment depends on symptom burden and exacerbation risk. Group A patients who have low symptoms and low exacerbation risk can start with any bronchodilator, preferably longer acting bronchodilator more than shorter acting. Group B patients who are symptomatic are recommended dual bronchodilators with LABA plus LAMA. Group E patients who have frequent exacerbations should also start with dual bronchodilation, and triple therapy may be considered if blood eosinophil counts are high. Follow-up pharmacological treatment in COPD. At follow-up, first step is to assess patient's response to current therapy. If patient is stable, we continue the current treatment. Treatment is adjusted only if dyspnea persists or patient has exacerbations. If persistent dyspnea is the main problem, start with single long-acting bronchodilator, either LABA or LAMA. If symptoms persist, escalate to dual bronchodilation with LABA plus LAMA. If patient still remains symptomatic, consider switching inhaler device or drug molecules. Implement or escalate non-pharmacological treatments such as pulmonary rehabilitation. Consider adding ensifentrine. Also, evaluate for other causes of dyspnea and treat them properly. If one or more moderate or severe exacerbations, treatment depends on blood eosinophil count. In first step, we start with LABA or LAMA. If exacerbations persist, escalate to LABA plus LAMA. Then add ICS based on eosinophil count. If blood eosinophil counts are more than 300, escalate directly to LABA plus LAMA plus ICS. If eosinophil counts are between 100 to 300, ICS can also be considered when exacerbations continue. Further escalation in patients with triple therapy. If patient continues to have two or more moderate exacerbations or one severe exacerbation despite triple therapy, and if blood eosinophils are more than or equal to 300, consider biological therapy such as dupilumab and mepolizumab. And other additional options include rofumilast in patients with FEV1 less than 50% and chronic bronchitis, and azithromycin preferentially in former smokers. In all treatment, single inhaler triple therapy is preferred because it improves the adherence, it is more convenient, and may be effective more than multiple inhalers. Also, ICS de-escalation should be considered if patient develops pneumonia or significant side effects. However, if blood eosinophils are more than or equal to 300, stopping inhaled corticosteroid may increase the risk of exacerbations. Role of inhaled corticosteroids. Inhaled corticosteroids are not universally indicated in COPD. Inhaled corticosteroids are more beneficial in moderate exacerbations more than or equal to 2 per year, and there is history of hospitalization for exacerbation of COPD, and eosinophils more than or equal to 300, and also when there is a concomitant or history of asthma. Inhaled corticosteroid can be considered in cases where the eosinophil count is 100 to 300, and also there is one moderate exacerbation per year. ICS may be avoided in patients with recurrent pneumonia, low eosinophil count, and also with history of mycobacterial infections. Management of COPD patients already on LABA plus ICS. If patient is already on LABA plus ICS, there are three scenarios. In first scenario, if there is no current exacerbations and previous good response, then management of the patient depends upon the symptom load. In low symptom load patients, continue the same LABA plus ICS treatment. If high symptom load, escalate to triple therapy, that is LABA plus LAMA plus ICS. In another scenario, patient currently on LABA plus ICS and there is no relevant exacerbation history, consider switching to LABA plus LAMA treatment. And if there is exacerbation, we can escalate to LABA plus LAMA plus ICS treatments. In third scenario, when there is current exacerbations on LABA plus ICS treatment, if blood eosinophil count are less than 100, consider switching to LABA plus LAMA, and if blood eosinophil counts are more than or equal to 100, consider switching to LABA plus LAMA plus ICS. Importance of inhaler technique. Incorrect inhaler technique is one of the most common reasons for poor treatment response. Even the best medication will fail if it is not delivered properly. Therefore, at every visit, inhaler technique must be checked and patients should be re-educated whenever necessary. Choosing the right inhaler. There is no single best inhaler for all patients. The correct choice depends on patient's ability to generate inspiratory flow, coordination, cognitive status, and affordability. A simple regimen with fewer devices usually improves adherence. If patient needs DPI, inspiratory flow of the patient must be very good. Hand-mouth coordination should be considered if patient is using MDI. If hand-mouth coordination is not well and poor inspiratory flow, we should consider MDI with a spacer. If patient is not able to get enough inspiratory flow even on MDA with spacer, we should advise him nebulization therapies. Non-pharmacological treatment in COPD. Non-pharmacological treatment in COPD. Essential non-pharmacological treatment involves smoking cessation and pulmonary rehabilitation. Smoking cessation should be considered in all groups A, B, E, and pulmonary rehabilitations in groups B and E should be started during or within 4 weeks of discharge. Vaccination should also be considered in all groups based on local guidelines. Recommended non-pharmacological treatment involves physical activity for all groups A, B, and E, and in selected patients, oxygen therapy, non-invasive ventilation, and surgical and bronchoscopic interventions should be considered. Identify and reduce risk factors. Risk factor reduction is the most important step in COPD management. The primary risk factor worldwide is tobacco smoking. In many developing countries, biomass fuel exposure is also a major cause. Occupational exposure and air pollution further contribute to disease progression. Identifying and reducing these risk factors is essential because no pharmacological therapy can compensate for ongoing harmful exposure. Smoking cessation. Smoking cessation is the single most effective intervention in COPD. It slows the decline in lung function and improves survival. A structured 5-step approach is recommended. First, ask about smoking status at every visit. Second, advise the patient strongly and clearly to quit. Third, assess readiness to quit. Fourth, assist with counseling and pharmacological therapy such as nicotine replacement therapy, which includes gums, sprays, lozenges, varenicline, and bupropion. Include at least one pharmacological therapy if there is no contraindication. Finally, arrange for follow-up to prevent relapse. Vaccination in COPD. Vaccination is a critical part of COPD management. Vaccine recommended includes influenza vaccine, which is taken yearly, pneumococcal vaccination recommended according to GOLD guidelines is PCV20 or PCV21. COVID-19 vaccination is also strongly recommended, which is taken based on WHO and CDC recommendations. Age-appropriate vaccines such as Tdap for those who are not vaccinated in adolescents. Herpes zoster vaccine to be considered in COPD patients with age more than 50, and respiratory syncytial virus vaccine in age more than or equal to 50 and or with chronic heart and lung diseases. Preventing infection is a major strategy in COPD morbidity reduction. Pulmonary rehabilitation. Pulmonary rehabilitation is one of the most effective non-drug intervention in COPD. It should be started in patients during or within 4 weeks after discharge from COPD exacerbation. What are the benefits of pulmonary rehabilitation? It improves exercise tolerance, reduces dyspnea, enhances quality of life, and reduces hospital admissions. It should be offered to all symptomatic patients whenever available from GOLD Group B and Group E. Long-term oxygen therapy. Long-term oxygen therapy is indicated only in patients with severe resting hypoxemia, PaO2 less than or equal to 55, or PaO2 less than 60 with complications such as pulmonary hypertension, congestive heart failure, polycythemia. It should be given at least 15 hours per day to keep saturation more than or equal to 90, and should be rechecked in 60 to 90 days if the oxygen therapy is still indicated, and also to assess the effectiveness of oxygen therapy in mitigating hypoxemia. Long-term non-invasive ventilation. Long-term non-invasive ventilation may be benefited in selected patients with COPD, patients with chronic hypercapnia, PaCO2 more than 53, and history of hospitalization for acute respiratory failure. It can reduce hospitalizations and may improve survival in carefully selected cases. Overview of surgical and bronchoscopic interventions in COPD. This image summarizes surgical and bronchoscopic interventions used in selected patients with advanced COPD. These procedures are considered when patients continue to have persistent symptoms, chronic mucus production, frequent exacerbations, or severe dyspnea despite optimal medical treatment. In chronic mucus production, the main underlying disorder is chronic bronchitis. Bronchoscopic intervention includes nitrogen cryospray and rheoplasty, which reduce mucus producing cells. In frequent exacerbations, causes may include chronic bronchitis, bulle, emphysema, or tracheobronchomalacia. A option here is targeted lung denervation, which can reduce airway nerve activity. In patients with severe dyspnea due to bulle, emphysema, or airway collapse, several interventions are available, including giant bullectomy, large airway stenting, endobronchial valves, coils, thermal vapor ablation, lung sealants, lung volume reduction surgery, and lung transplantation. These procedures mainly work by reducing hyperinflation and improving lung mechanics. Overall, these interventions are reserved for selected patients who remain symptomatic despite optimal medical therapy. Lung volume reduction surgery. Lung volume reduction surgery involves removing the most diseased portion of lung to reduce hyperinflation. This allows the remaining healthier lung to function more efficiently. Evidence shows that LVRS improve survival in carefully selected patients, particularly those with upper lobe predominant emphysema and low exercise capacity after pulmonary rehabilitation. However, patient selection is critical because procedure carries significant risk. Bullectomy. Bullectomy is considered in patients with large bullae that compress the surrounding lung tissue. Removing this bullae allows compressed lung to re-expand, improving ventilation. In selected patients, the procedure reduces dyspnea, improves lung function, and exercise tolerance. However, evidence supporting bullectomy is less robust compared to lung volume reduction surgery. Lung transplantation in COPD. Lung transplantation is an option for patients with very severe COPD who remain symptomatic despite maximal medical therapy and are not candidates for lung volume reduction procedures. It is shown to improve the quality of life and improve the functional capacity. Referral should be considered if board index more than or equal to 7, patient not candidate for LVRS, and one of the following: hospitalization with hypercapnia, pulmonary hypertension or copulmonale, FEV1 less than 20 with low DLCO, or homogeneous emphysema. Bronchoscopic lung volume reduction. Bronchoscopic lung volume reduction is a minimally invasive procedure alternative to surgery. This technique aims to reduce hyperinflation by collapsing most diseased lung segment. This leads to improvement in exercise tolerance, symptoms, and quality of life. Usually, procedure benefit at 6 to 12 months, and the techniques include endobronchial valves, coils, and vapor ablation. Endobronchial valves have the strongest evidence, while coils and vapor ablation also show benefit in selected patients. Other bronchoscopic therapies. Several newer bronchoscopic therapies are currently under investigation. This includes cryospray, rheoplasty, and targeted lung denervation. These approaches are being studied mainly in patients with chronic bronchitis and refractory exacerbations. These approaches remain investigational and are not a part of routine clinical practice. Summary of surgical and interventional pathway in advanced COPD. Management of advanced emphysema follows a stepwise approach. First, the emphysema phenotype and degree of hyperinflation are assessed. If a large bullae is present, bullectomy may be performed. If not, distribution of emphysema is evaluated, either heterogeneous or homogeneous. Collateral ventilation and fissural integrity are then assessed. Based on these findings, patient may undergo bronchoscopic lung volume reduction or surgical lung volume reduction. If none of these options are available, lung transplantation may be considered. Benefits of different intervention. Different interventions provides different benefits. Smoking cessation and oxygen therapy improves survival. Dual bronchodilation improves symptoms. Triple therapy reduces exacerbations. Pulmonary rehabilitations improve functional capacity and quality of life. Palliative and end-of-life care in advanced COPD. Principles of palliative care in advanced COPD. Palliative care in COPD should not be delayed until the terminal phase. It is appropriate at any stage of severe disease and focuses on symptom relief and quality of life. Clinicians must actively recognize palliative needs and integrate symptom control into routine management. End of life care discussion should address resuscitation preferences, advance directives, preferred place of death, and involvement of family member. Symptom control in advanced COPD. Main goal of palliative care is the symptom control. Breathlessness can be reduced with low-dose opioids, oxygen when indicated, fan therapy directed to the face, and neuromuscular electrical stimulation. Nutritional supplementation is important in malnourished patients as it improves respiratory muscle strength. Fatigue can be managed with education, pulmonary rehabilitation, proper nutrition, and mind-body techniques. To summarize, COPD management requires combination of pharmacological and non-pharmacological strategies. Smoking cessation remains the most important intervention. Dual bronchodilation is the backbone of therapy. Inhaled corticosteroids are used selectively based on exacerbation risk and eosinophil counts. Pulmonary rehabilitation is essential and long-term oxygen therapy improves survival in patients with severe hypoxemia. Surgical and bronchoscopic interventions should also be considered in patients with advanced emphysema who are not improving on pharmacological treatment and pulmonary rehabilitation.